So, good evening to all. Hope all are fine. All of you are fine. So, today we are dealing mainly with cell adaptation and cell injury. This is actually the part one of the whole chapter. It's a huge chapter. So, we have divided into three parts. So, today we'll be dealing with all about cell adaptation and all about what is cell injury, where it occurs, how it occurs, and all. Its classification will be dealt in the second part. Okay, so now first coming to cell adaptation. What is cell? We'll go into that. First, we'll see about the cell responses to stress and noxious stimuli. See, a normal cell means a cell which is working under all, it is normally functioning under all circumstances. Physiologically and metabolically, all the organelles in the cell are equally working properly, and the cell is doing its job in a very normal fashion. It's at equilibrium. To say in one word, it is at equilibrium, which is called homeostasis. So it's written here, equilibrium maintained by a self-regulatory process. So our normal cell is in that state now. Now, when the cell is exposed to some sort of mild injury or a physiological injury, which is called stress, can be anything. Can be a mechanical stress due to pressure or trauma, or it can be a noxious stimuli, which is dry heat or too much cold, so which the cell can't tolerate in usual circumstances. So all those come under the stress. So if the cell faces a stress, it goes in for a process called adaptation. It's just like how we adapt to different circumstances, to different climate, weather. Just like that, cell also tries to adapt to its abnormal circumstances. So this is the definition of adaptation. It is a reversible change in the size, number, phenotype, metabolic activity, or the function of the cell. Okay, that's reversible change in the size, number, phenotype, metabolic activity, or function of the cell in response to the physiological changes or mild injury, which we told as stress here, in their environment. This which will result in a new steady state to preserve the cell structure and function. So it is a physiological change, a small change that the cell goes into when it is facing a stress. It will come into a new state so that it can preserve its own cell structure and function. So that is adaptation. Now, when it comes to a certain point that the cell is not able to adapt, how much it has tried, because either because the stimuli is too prolonged, the stimuli is too much for the cell to tolerate, then the cell goes in for cell injury. Or if the stimulus itself is too much injuries that the cell can't even adapt in the first place, it will go in for cell injury. Cell injury is the injury that simply the slight injured condition of a normal cell. It is not able to function normally like it was before. So cell injury is again of two kinds, reversible and irreversible. Now, irreversible, if the noxious stimuli, whatever, as I told before, like dry heat or cold, if that is very mild and transient, only for a short period of time it exists, it becomes reversible cell injury, and when the conditions are fine, it comes back to its normal cell. See, it's written here. Now, if it is very severe and if it is progressing, there's no decrease in such a stimuli, then it goes for irreversible cell injury. And the two main kinds of reversible cell injury are necrosis and apoptosis. So these are two kinds of cell death, which we'll be dealing later. So now we'll go into adaptations. So the type of adaptations, major type of adaptations are atrophy, hypertrophy, hyperplasia, and metaplasia. So these are the main four types of adaptation. Okay. Now, this is the way the cell takes a first step for adaptation. By these three forms, it will try its best to keep its tolerance up. But if that doesn't, give an advantage, that is, if the limits of adaptive responses are exceeded, or if the cells they are exposed to the injurious agents for a very long time, then what happens? It can't adapt. Just as we told before, it can't adapt. So it will go into a sequence of events that will lead into cell injury, which we'll be dealing again later. So now we'll come into atrophy. So atrophy is the decrease in the size of the cell or decrease in the number of cells or tissues. Okay, so that is atrophy. So when that occurs, so that's again a cell adaptation when there's a noxious stimuli. So that leads to a decrease in organ size. Now the etiology, that is the cause why atrophy occurs. The cause of atrophy is physiological and pathological. Both are there. It's not okay. So, physiological atrophy. Physiological atrophy is very common during normal development. That is, during normal development of the fetus. As we have already studied in embryology, there are many structures that form in the course of the formation of our organs. They just form and they just degrade off. So that's an important example of physiological atrophy, like atrophy of notochord, the styroglossal duct. All those embryonic structures degradation is a example of physiological atrophy. Then a decrease in the size of uterus, which occurs after parturition, which is otherwise called involution, is also an example of physiological atrophy. And when there's aging, when as age passes, the body becomes weaker and weaker. So the brain might face cell aging. So that is also an example of physiological atrophy. Okay, that's a small example. Now, pathological atrophy. Pathological atrophy can be localized or generalized. Pathological atrophy, I have actually divided it. What happens in pathological atrophy? There's decrease in a lot of things and increase. Okay. So first we'll see there's a decrease in nutrition, which you call as nutritional or starvation atrophy. There's a decrease in blood flow to the organs, which is called ischemia or ischemic atrophy. So then there's a decrease in neural supply, which is called denervation atrophy. There's a decrease in hormone secretion and production, which is leading to loss of endocrine stimulation. There's a decrease in workload, which leads to disuse atrophy. And if there's an increase if the atrophy, the pathological atrophy, you can see that there's an increase in external pressure or pressure atrophy. Pressure atrophy actually means, I can tell you that, it is like when tumor forms, like pituitary tumor, when it is formed, it will compress over the pituitary gland. So that can lead to the early atrophy of pituitary glands. There are many other cases how the tumors can cause atrophy. That's that causes external pressure and stimulates atrophy. Now we'll go into detail about nutritional atrophy. Nutritional atrophy is actually, as it is shown here, it is associated with protein and calorie malnutrition. There's a decrease of protein. Everything is decreased, right? The cells are decreased, so there's no protein production there. All the components are getting decreased. So there's malnutrition of the cell. So if it is widespread, it can lead to a condition called marasmus. Then the skeletal, then that's one scenario. Then it can also lead to skeletal muscle wastage, which is otherwise called as cachexia. Cachexia is seen in two cases usually. The chronic, that's just for your knowledge. You just need to know it is associated with protein, calorie malnutrition and the skeletal muscle damage. Okay, this cachexia is actually seen in chronic inflammation disease. There you have chronic production of this tumor necrosis factor. So that can lead to loss of appetite. So that can again, stimulate atrophy. Also sometimes seen in cancer conditions. Okay. Next we go into ischemic atrophy. Ischemic atrophy is associated with decrease in blood supply. When there's a decrease in blood supply, what happens? There's occlusion of there's due to some blockage or narrowing, that will occur block, that is occlusion. So that leads to progressive loss of the blood supply to tissues. That again leads to cell atrophy. So that is called ischemic atrophy. A best example of ischemic atrophy is atherosclerosis. In atherosclerosis, there's deposition of the lipids, fats, all those. They are, they get deposited on the walls of the arteries. So there's narrowing of the blood vessels. This will lead to decreased supply to the brain. This will decrease the supply to the brain. That will again lead to the progressive atrophy of brain cells. Obviously, the brain always needs blood supply, and if there's some stoppage in blood supply, there's going to occur severe problems. So when there's decreased blood supply to the brain, there'll be progressive atrophy of the brain cell, and this atrophy is called senile atrophy. Again, you have to remember, if the conditions come back to normal, the person is going to come back to normal. Nothing is going to affect it so much. But if it goes for that, then it can go in for cell death. So this is called senile atrophy. So as far as the brain cells are concerned, the progressive atrophy of the brain cells, when it is not getting adequate blood supply, is called senile atrophy. This is also seen in the heart. That's what I've written here. It also affects the heart in long run. Now what you see here is the atrophy of brain. Actually, this is the left one that you see is a normal brain of a young adult. It's very normal. But on the right side, you can see that there's atrophy of the brain. That is due to atherosclerotic cerebrovascular disease. As I told you now, there's occlusion of the blood vessels. The brain is not getting enough blood. So there is, you can see there's increased space in the gyri sulci. So that indicates the progressive atrophy, the senile atrophy, which is occurring in the brain. Next, we come into denervation atrophy. Denervation atrophy, the normal metabolism and the function of the skeletal muscles they depend on the nerve supply. So all the skeletal muscle function, supply, everything is all their functions, everything is dependent on the nerve supply. So if there's any damage to the nerves under any circumstances, anything happens, then what happens? There will be progressive skeletal muscle atrophy also along with nerve atrophy. So that complete process is called denervation atrophy. Next, as I told you, there's decrease in hormones, right, for atrophy. So that leads to loss of endocrine stimulation. That is, there are some, almost all the reproductive organs, they work with stimulation from the hormones. Like all the reproductive organs, including breast, they all work under hormone stimulation. So that is because that is required for their physiological work, for all their functions, everything. So it is required for the normal metabolism and function. So it's lost. When it is decreased, that leads to atrophy of the organs. We already know in all those congenital disorders, or maybe Klinefelter syndrome, all those cases, that where there is atrophy of the reproductive organs and all those. So there is decreased endocrine supply as a result of it. So in atrophy, you have to understand there is decrease in hormone secretion. And a physiological atrophy is also an example. That is physiological atrophy which occurs of the the endometrium, the breast, the vaginal epithelium after menopausal stage, the women faces, because obviously there is decrease of estrogen supply. Next is disuse atrophy. That's something very important. As you know, the workload is decreased. That leads to disuse atrophy. So that occurs usually when you have a patient who is under bed rest due to some fracture or some other accident or anything, and he or she is kept immobile. In such a case, what happens is there will be if that occur initially, if there's no movement being done, then it will start with atrophy or shrinkage of skeletal muscle cells. If that is very transient, if it is very for a short period of time, it will be reversed and come back to its original form. But if this immobilized state persists for a very long time, what happens? The cell muscles, they'll shrink, they'll decrease in some number and size, and the muscle atrophy with increased bone resorption will occur. Finally, that results in osteoporosis of disuse. So first the muscle atrophy will occur, so there will be disuse of muscle. Then if it is again not ignored, again not continued, it will lead into osteoporosis. That is, it will affect the bone also, osteoporosis of disuse. So that's why it's always recommended after any such problems, you have to do movement. Like they encourage physiotherapy so that such conditions won't come up. Then we are going to talk about the pathogenesis or mechanism of atrophy. What occurs in atrophy? What happens? Why this happens? Okay, that is, there's increased protein degradation and decreased protein synthesis. Increased protein degradation and decreased protein synthesis. And because of the whole overall decrease in metabolic activity, this is seen. And it also results in autophagy, which is seen with atrophy with autophagy. First it starts with atrophy, and in certain conditions we go for autophagy. We'll go into that, where it comes. Now this mechanism, atrophy has two scenarios to be shared. First is we'll talk about the decreased protein synthesis or increased protein degradation. So see, increased protein degradation, this is just for knowledge, it occurs via ubiquitin proteasome pathway. That is, all these protein degradation is occurring. So there are a lot of protein, the degraded products of protein. So this will activate ubiquitin ligase. So these what does this ubiquitin ligase do? They'll attach the ubiquitin to these degraded proteins and they'll send them to where? Proteasome. So that is this pathway, that is called this pathway. And there again protein degradation. So there will be so much accelerated proteolysis. So there again there's a chance, if sometimes a chance of cancer cachexia. So there, atrophy has started in that way. The second scenario, as I told you, is autophagy. Now, what is autophagy? Autophagy refers to the lysosomal digestion of cell contents. And one thing you have to understand is we talked about a lot of atrophies. So here, autophagy is only seen in nutritional atrophy, like when there's starvation of the cell, when the nutritional status of the cell is down, the cell goes in for atrophy with autophagy. Because why this autophagy occurs? Because it is a survival mechanism of starved cells. If they are deprived of protein, they'll try to they'll eat at themselves up, to say in short words. That is, they'll kill themselves. The lysosomes will kill themselves up, the whole cell up, so that the nutritional demand that the cell tells, like cell wants proteins or nutrition, it is not available because everything has been decreased, the metabolism has decreased, nothing is there. So what does the cell do? It just dies off. So that's a simple concept here. So for this, the multi-protein complexes initiate the formation of autophagic vacuole or autophagosomes near the SCR. That's how it happens. Autophagic vacuole, they'll form autophagosomes will be formed near SCR. This will fuse with this lysosome to form phagolysosomes. So they'll digest this material and they'll recycle it, and then the cell is killed. Autophagy is complete. Now, this is just for information. That is, most of the cells, they'll respond to this kind of autophagy, but there are some cells which will try to resist autophagy. They'll just resist it. So what happens is that will lead to formation of cell debris. Cell debris is formed. There's formation of residual. This cell debris is converted into residual bodies. Okay, so they won't be subjected to autophagy. Instead, they'll form cell inclusions inside the cell. So in this case, lipofusins are formed. So if it is increased in amount, you can see there's brown atrophy in those cells, brown discoloration of the cells. Now, physiological causes of autophagy with atrophy, which I've already told: starvation, which leads to atrophy followed by cell death. Then there's turnover of organs. Organs are not able to function properly, so they try to adapt. They are trying to adapt. That's the turnover that is meant. Then there's aging, death. So this is physiological cause actually. Anyway, the old cells, they starve, they die. So that is a physiological thing. But then pathological cases, if there's misfold of proteins in certain cells, like which is evident in the neurodegenerative disorders like Alzheimer's and Huntington's disease, there's misfold of proteins means there'll be full kind of mutated manner. The cell won't be working properly. There'll be atrophy, so that leads to degenerative disorders. Then infectious organs like mycobacteria, Shigella, HSV. So all these prolonged action can lead to the atrophy of the cells where they are targeting. Okay, their targeting cells can go get atrophied when their division happens. Then inflammatory bowel disease, cancer. So all these are cases where you can see atrophy. Okay, this I'll tell you. 1 second, we'll come here. Clinical features and prognosis of atrophy. So, there's decrease in size of cells and organs. So, size and cell, the size and cell of organs, everything is decreased. Number is decreased, size is decreased. So, what happens? Functioning is completely decreased. So, as we already know, if the stimulus which causes this atrophy, this whole atrophy is withdrawn, if the stimulus is withdrawn, then the cell can come back to normal because it's an adaptation. But if this is continued, the cell will go in for a cell death, which will be completely irreversible. Next, we go in for hypertrophy. So, before we go into hypertrophy, we'll just go through this. That is, cells, they are based on the proliferative potential. All the cells divide. We have just studied like all cells divide, but it's not like that. All cells don't divide. They have a particular way. Some divide only at one time, like that. So, based on the proliferative potential, there are 3 kinds: labile, stable, and permanent. You just need to know what they are. See, labile proteins, they are continuously dividing. They'll continuously divide. They'll continuously complete the whole cycle of M to G1 phase. Mitosis, all the mitosis, and G1, G2, all the phases will be completed by the labile cells. Here, these are the examples: epidermis of skin, surface epithelium, not that important. Then stable cells means they'll go into a quiescent stage or G0 stage. almost, I think, all the cells of the visceral organs which you see here are under stable cells. Permanent cells, the cells they have left the cell cycle in between, and they won't be completing. Maybe they will complete one cell cycle and they just leave off. They won't continuously go for a cell cycle, or they'll stop in between. That's it. So that's growth is permanent. So examples are neurons, cardiac muscles, skeletal muscles. Okay, now we'll go in for hypertrophy. So what is hypertrophy? Hypertrophy, that is increase in the size, increase in the cell size, which occurs in all cell types. These three cells which we have discussed, labile, stable, permanent. So all these cells can be exposed to hypertrophy. So now etiology of hypertrophy. Hypertrophy can be physiological or pathological. Physiological causes we'll see, it can be hormonal change. Again, when there's during pregnancy, there'll be increased size of uterus which occurs, the increased size of breast for lactation. So all these are actions of estrogen. So estrogen is surplusly increased. The estrogen cells, they increase in size so that they are able to secrete more amount of estrogen. So that's an physiological cause. Then increased workload, that is in bodybuilders who do a lot of workout and all, they'll face they'll have skeletal muscle hypertrophy. They'll be facing skeletal muscle hypertrophy so that their muscles are built up. Now, pathological cause is only one cause, that is increased workload in hypertension. That is, during hypertension, the heart, there's increased blood pressure, there's increased heart rate, the blood tries to pump more than usual. There's a lot of stress for the heart. So, heart can go in for hypertrophy. You might have heard of left ventricular hypertrophy, right? Yeah. So, left ventricular hypertrophy, where the cell tries to, the cardiac cells try to adapt to that increasing blood pressure. But if that is not treated properly, the heart then the person who is having left ventricular failure, hypertrophy, can go in for a cardiac failure. Now, pathogenesis, how hypertrophy occurs. Hypertrophy, it occurs due to one is mechanical stress or stretch, increased protein synthesis, increased growth factors, and adrenergic hormones. All these you can see in the biochemical mechanism of myocardial hypertrophy. So, myocardial hypertrophy is a pathological condition. So, what happens is, if you take a myocardial cell, the myocardial cell has, mechanical sensors or integrins in their cell, at the cell membrane. Then they have growth factor receptors, they have hormone receptors. All these are present in a cardiac cell. So what happens is, when all these are extra stimulated, hypertrophy, right? So they are all extra stimulated. So that they'll go in for stimulate signal transduction pathways. So that will again lead to formation of transcription factors. All this process. So that will lead to in the all these things what we have seen, that is mechanical stress is increased, protein synthesis is very opposite to atrophy. Just remember like that. There's increased protein synthesis, there's increased, everything is increased, growth factors, proteins, adrenergic hormones, all production is increased. So overall there's a huge increase in mechanical performance. So that's it. Okay, so in the case of heart gets stressed out, and if this is not reversed, it goes for cardiac failure. Then what happens is, if there's so much of workload for the organ and nothing is done, what happens? What happens is they'll be associated with switchover of the contractile proteins from adult to fetal form. So all these cells will be trying their best to keep up with working of production of all these growth factors and proteins, and there'll be so much load on the adult cells. So what happens? The adult cells will convert to fetal cells, because fetal cells are economically and energetically more slower, but they're more efficient to increase the workload. So I told you workload. That's how the workload will be so much increased. So it will take the help of fetal proteins. That's what it is told here. See, there's a switchover of contractile proteins from adult to fetal form, so that they can keep up the workload. Example, the alpha isoform of myosin heavy chain will be substituted by beta isoform. Then morphology, there will be increased size of cell. Okay, increased size of cell. That will lead to increased size of organ and tissue. There will be increased protein content in each cell because so much of activity. See here, you can see this is an example, a best example of physiological hypertrophy of the uterus right after, which is during pregnancy. This is the histological appearance of that. Coming on to the clinical features and prognosis of hypertrophy. Again, the cells are too much, there'll be increased workload per cell. Increased work is there per cell. It returns to normal if the stimulus is withdrawn. Again, like hypertrophy itself, if the stimulus which makes it so much work so much that it has to go into hypertrophy, if that stimulus is removed, then it comes back to normal. But persistence, if this is not removed, if this is persisting, then it can lead to degenerative changes or cell injury. Okay, so next we'll go in for the third one, that is hyperplasia. Hyperplasia is the increase in the number. Hypertrophy is increase in the size, and hyperplasia is increased in the number of cells. Don't get confused. Okay, so this is increased in the number of cells. And one more difference is that I told you hypertrophy, we have read, it occurs in all three types of cells: labile, stable, and permanent. But hyperplasia occurs only in labile and stable cells. That means only cells which are capable of division and not in permanent cells. So you never see hyperplasia in permanent cells. Now, etiology of hyperplasia. Hyperplasia can be physiological or pathological. Now, action of hormones and growth factors. Physiological factor one is action of hormones and growth factors like in lactation, and when there's a need for functional capacity of the hormone sensitive organ, a compensatory increase of the following tissues. That is, I'll tell you, like if there's any surgery, if there's any resection due to some tumor, whatever, if a small part of the organ is missing, and if the body feels that the organ has to have some mechanism to work more to produce a hormone, like if you take liver, or if you take any gland which has been resected for some reason and its size has decreased, its hormone production has decreased, and the body thinks that it has to come back to its normal form so that it can work more, then there will be regeneration. What we say in simple terms, there will be regeneration of liver. That is hyperplasia that is actually occurring there. There will be hyperplasia. There will be increase in the number of cells, so that hormones are being produced. So these are the two physiological conditions in lactation and as a compensatory method. Even you can see regeneration of kidney, nephrectomy. When you dissect a small part of kidney, it tries to regenerate back by the process of hyperplasia. Then pathological. The excess inappropriate action of hormone. Then when there is excess, which is not required, or action of hormones and growth factors can go in for a pathological hyperplasia. The best example, as you have all heard, is benign prostate hyperplasia, BPH, that which occurs due to the increased adrenergic stimulation. In the sense, there's an active metabolite of testosterone, dihydrotestosterone, dihydrotestosterone, so that its increase leads to actually BPH. Then there is also endometrial hyperplasia, due to which similar cases, it's also pathological condition. So when there is menstrual cycle, there's increased loss of blood. And sometimes, hyperplasia can also be induced by pathogens like human papilloma virus, which will manifest in the form of skin warts. So if it's not treated, it can go in for hyperplasia if it's not treated promptly. Now, pathogenesis, the growth, why this occurs? How this pathology occurs. That is, the growth factors are increased, which leads to increased metabolic activity of the cell. That is, there's, as I told you, regeneration, proliferative capacity of the cells will increase. So that's how hyperplasia occurs. Morphology, there's increase in the number of cells, which I already told. Sometimes size of cells will increase. Sometimes. Okay, so you have to understand one thing. Some hyperplasia is increase in the number of cells only. Sometimes, if there's increased hyperplasia, sometimes hypertrophy can accompany it. That's all. Hypertrophy is never followed by hyperplasia, but hyperplasia, if it is too much, sometimes there may be hypertrophy. That's all. Next is clinical features of hyperplasia. There's increase for neoplasia or dysplasia. So such a condition can occur. Next we go into metaplasia. Now, you should not confuse between what is hyperplasia and metaplasia, because hyperplasia is only increase in number of cells. But metaplasia, the word itself says meta means differentiation, it changes. So, reversible change of one type of adult cell to other type of adult cell in labile and here this also, that is in hyperplasia and metaplasia, this condition occurs only in labile and stable cells. Both conditions won't occur in which cells? Yeah, permanent cells. It will never occur in that. So metaplasia means differentiation of cells, not the growth. That is not the increase in the number of cells like hyperplasia. Etiology. One more thing. Metaplasia is always pathological. It's never physiological. So let's see the pathological features. First of all, chemical exposures like tobacco and cigarette smoking that can lead to metaplasia of lung tissue. That is lung tissue. Obviously, you know, it is ciliated columnar epithelium. So if it is too much of exposure to tobacco and smoke can metaplase it into stratified squamous epithelium. Then vitamin A deficiency, if it is prolonged, it can cause squamous metaplasia of the respiratory system again. Then if there is inappropriate site of GI secretion, like gastric secretion in esophagus, that occurs in the case of Barrett esophagus. When there's narrowing of the esophagus, the esophageal epithelium is changed. We'll read about that soon. Then there's chronic infection. When there's chronic infection like of H. pylori, if it is not treated, can go in for metaplasia. Then mechanical stimuli like mechanical traumas, the deposition of calculi in the gallbladder, pancreas, the urinary bladder, bile duct, all those glands, in that glands if the secretion turns into stones or calculi, so that can also lead to metaplasia. Then this is another condition, that is formation of cartilage, bone or adipose tissue in normal tissue called connective tissue metaplasia. This is a special condition. You know, there's abnormal, and you can say abnormal formation of cartilage, bone or adipose tissue in normal tissue. So that is connective tissue metaplasia, which is called as myositis ossificans, after intramuscular hemorrhage. So it's a special case. We'll again encounter that. Pathogenesis, why this occurs. Okay. There's reprogramming of the stem cells to differentiate into cells that are better able to withstand stress. That's what I told. There's a differentiation of the cell. When the conditions are changing, the cell will change from what it is to totally another form. Then it is accompanied by loss of cellular functions. That is like, for example, if you take the lung had a ciliated columnar epithelium. So it had cilia. But when metaplasia occurred, what happened? It converted to stratified squamous epithelium. So the cilia is lost. So that's the meaning. Then morphological changes. The ciliated columnar epithelium changes to squamous in bronchial tissues due to tobacco smoke, which we already spoke. The squamous epithelium changes to intestinal or the gastric type of epithelium. That is secretory epithelium due to gastric reflux secretion in the esophagus. Esophagus, there will be increased abnormal secretion. We don't have any secretion in esophagus normally, but if there's Barrett esophagus or narrowing of the esophagus, there will be increased gastric production, gastric acid secretion. So the cells will change, metaplasize. Then transitional urothelium of the bladder. You know, the urothelium is transitional urothelium is the epithelium of the bladder. So that will begin to change to squamous epithelium due to prolonged deposition of caliculi or stones in the bladder. So you can see here, these are the normal columnar epithelium and how they are in respiratory epithelium, how they are converting to squamous metaplasia. You can see here. So this is the histological diagram. Then mesenchymal tissue also shows features of metaplasia. Like that's what we spoke before here. I hope you remember. That is this one. This myositis ossificans. That is what is being mentioned here. Okay. All the mesenchymal tissue, there will be abnormal deposition. The deposition which is not to be there will be there. Like cartilage formation in some other cell which never occurs in normal circumstances, or fibrous tissue will be replaced by some other tissue. Very abnormal condition. So that is also an example of metaplasia. Now clinical features and prognosis of metaplasia. Here you can see that there's a loss of normal functions with survival advantage. Example, the loss of ciliary function. I told you there's loss of ciliary function. That is a clinical feature. And if this is a transient and mild, as we already told, if the stimulus is mild, it comes back to normal. If not, it goes in for a malignancy, cell death, whatever, so on. So that's all about cell adaptation. Cell adaptation is over with here. We have studied about atrophy, we have studied about hypertrophy, we have studied about metaplasia, and we have studied about hyperplasia. Now we're going to next topic. That's why I changed the color. It's a new topic, cell injury. Now, cell injury. When does cell injury occur? We already spoke how cell injury occurs. The cell tries to adapt, but it fails. See, adaptive responses fail. The injurious agent is inherently damaging. That is not stopping. It is neither decreasing and is very progressive. And the cell is already compromised. Cell is already, it is not able to tolerate the stimuli at all. Even by adaptation, then we'll go for cell injury. Cell injury is again of two kinds. As we already spoke, reversible and irreversible. So if there's an injurious stimuli, the cell first tries to go in for reversible cell injury, and as I've marked here, part 1, if 1 and 2 I've marked here, I've seen here, yeah. So if in this point of time the cell tries to come, if the stimulus that makes the cell injured is withdrawn in this period, then means that is before the point of irreversibility. If it is reversed, then it will come back to its normal cell form. But if the condition of the cell crosses the point of irreversibility, what happens? It will go for irreversible cell injury. So there's no coming back. Reversible cell injury is of two kinds, which you have to know: cell swelling and fatty change. Irreversible cell injury is of two kinds, that is necrosis and apoptosis. Now, reversible cell injury. Here the cell damage occurs, but the cells are viable. Cells, a bit of damage occurs, but they are living. They are not completely injured. There's withdrawal of etiology followed by return. Yeah, there's withdrawal of etiology. It can come back to normal. The morphological changes are what we told: cell swelling and fatty change. Irreversible cell injury. Irreversible cell injury, the cell is non-viable. Non-viable in the sense it can't come back to its original form. There's nothing, no conditions withdrawn can bring it back to it. That is called viability. There's no, withdrawal of etiology is again not possible. No morphological, that's what we read now. Necrosis and apoptosis. Now, etiology of cell injury. Now, this is a general thing. How cell injury occurs? Cell injury starts with hypoxia, usually. If an injury stimuli can be, that will come into that, or hypoxia. So first, hypoxia. Hypoxia means decreased oxygen supply. It can occur in ischemic conditions where there's decreased blood supply, anemia where there's decreased oxygen carrying capacity of the blood, and decreased oxygenation of the blood, like in pneumonia or in bronchitis, or when there's poisoning, carbon monoxide poisoning, or high altitude cases, etc. Now, chemical agents and drugs. It can be any poisons like arsenic, cyanides, mercuric salts, which will directly react the cell and cause a lot of problems of cell injury, or toxins which are released from our body, or social agents like alcohol and tobacco, or environmental and air pollutants, insecticides, herbicides. Then the occupational hazards like asbestos, carbon monoxide exposure, and the therapeutic drugs. All these are the chemical agents. Physical agents can be any trauma, which we already discussed, any pressure to the organ, or any deposition, that is trauma. Extremes of temperature, hot or cold, heat or cold, any extremes, or any type of shock. Infectious agents like bacteria, virus, fungi. Nutritional agents, if there's overnutrition, which we saw in hypertrophy, or undernutrition that we saw in atrophy. Then genetic factors, if that is a intermediate condition, if that is over or too much, goes in for cell injury. Then genetic conditions, all the immunological factors, the aging factor, all these can lead to cell injury. Or if there's a deposition of an abnormal substance like blood, it's for example in abnormal locations, or if there's abnormal increase in the deposition of substances like water, salt, and hormones in increased amount in a normal substance, that can also lead to cell injury. Pathogenesis. Now, how it occurs? The extent of the cell injury depends on the type of injurious agent, its duration, and severity. So, what type of injurious agent the cell is facing? How much duration, how much time it is facing, how much severity it is. So, these three are the things that determines how much the cell injury will be decided by these factors. Like for example, type. I told you before, the noxious stimuli like dry heat or hot water. That's a type of noxious stimuli. How much duration it exists, the time factor, like 1 second to 1 hour, whatever. That the injury will be more depending on duration. Severity. The more the severity, the more the injury. Like increased temperature means increased severity leads to increased cell injury. Then it also depends on the type of cell, which cell is facing it. First we told about the injurious agent. Now it is about the cell which is facing it, how it will adapt and how is its genetic makeup. For example, in terms of oxygen requirement, the myocardial and striatal muscles, they can tolerate hypoxia for a definite period of time. Okay, that means both are under different duration. Like myocardia can adjust with like oxygen deprivation for some time, and skeletal muscles may be more like that. So that depends on this difference in genetic makeup and the difference in their adaptability. So that's an example. Then one or more essential cellular components is affected as a case of cell injury. Now we'll see the biochemical and functional changes that occurs as a result of cell injury. There's damage, this is very important, you have to note. There's damage of mitochondria, first of all, of a cell. So that will lead to decrease in ATP and increase in the reactive oxygen species. Then there's disturbance of the calcium metabolism. There's increase in, so when there's a abnormal increase in calcium in the cell, inside the cell. There's damage to cell membrane. And finally, there will be damage to DNA and the proteins. First, we'll go into mitochondrial damage and dysfunction. Mitochondria is actually sensitive to all kinds of hypoxia, toxin, and radiation, because it's too sensitive to all those, because that can immediately lead into cell injury or necrosis. Also the decreased survival signals of the damage to DNA. If the survival signals which signal the damage to DNA or cell, like there'll be some signal pathways which will signal that the cells are damaging or the DNA is damaging. If that is decreased, if those signaling power of the factors are decreased, then also there are certain proteins which will activate mitochondria to go in for apoptosis directly. Or when there's decreased ATP production and increased ROS, which we've already spoken. Then the reversible cell injury, if not reversed promptly, can lead to necrosis. There is also formation of mitochondrial permeability transition pore. If that is formed, then that is how mitochondria goes in for apoptosis. When it gets a message, when there are no factors which will tell that stop the damage occurring to cell. If there is nothing like that, then what happens? Mitochondria, there will be a pore, mitochondrial permeability transition pore will be formed on the mitochondria. So that will lead to apoptosis. Next is depletion of ATP. ATP depletion, obviously we know there's decreased oxygen supply in cell injury, or there's decreased oxygen supply. So when there's decreased oxygen supply, what happens? All your cycles which you've already learned, the Krebs cycle, all these are not working properly. So ATP is not being secreted. So that will lead to decreased energy function for cellular, there'll be decreased energy for cellular function. Again, the dysfunction of ATP dependent, also what happens? ATP is decreasing. So when ATP decreases, what happens? The ATP dependent sodium pump is also, the damage is occurring to that. It is dysfunction, it's not functioning properly. So that will lead to what? Increased sodium reflux. There is increased sodium, efflux. So there will be increased sodium inside the cell. There will be huge K plus efflux. There will be so much loss of K plus. And water, solute, everything will be so much accumulated inside the cell. You can imagine the cell will be swelled with all the sodium, water, solutes and all. So it goes in for cellular swelling. Now compensate. So what happens when there's hypoxia? This is the first, what we talked first are the things that are going to happen in the beginning. But if this hypoxia continues, what will happen? Obviously our body will try to go for an anaerobic glycolysis. That is, the glycogen which is in the liver is anaerobically divided so that you can supply the cells. right? So that ATP is produced. So that's the called compensatory anaerobic glycolysis. So what happens? The glycogen cell is like the cell glycogen is being decreased. From that lactic acid is being produced. So lactic acid production is increased. The pH goes up. The pH goes down because it's a lactic acid, right? So the pH is going down of the cell more than normal. Then there's decreased enzymatic activity and protein clumping. There's protein clumping occurs, chromatin formation and all occurs. There's protein synthesis is decreasing. That will lead to detachment of ribosomes from the endoplasmic reticulum. Finally, there's failure of calcium pump. So when there's failure of calcium pump, again there's a increased calcium influx into the cell than normal. So that can also stimulate cell damage. So we'll see. This is the small representation of that. It is ischemia. Ischemia is actually, we know what it is. It is decreased blood supply to an organ, leads to ischemia, the damage of to the tissue. An initial sign of damage to the tissue. So when that occurs, what happens? There will be oxidative phosphorylation process from the mitochondria. Because it is not getting oxygen, it is not getting blood supply, so it is not able to function properly. So the mitochondria will go in for oxidative phosphorylation. Oxidative phosphorylation will lead to decreased ATP. So when ATP decreases, what happens? Three things will occur at a time. As I told you already, the ATP dependent sodium pump will be dysfunctioning. So there will be decreased decreased functioning of sodium pump. Then anaerobic glycolysis begins, and detachment of ribosomes also occur. Okay, so when there's decreased sodium pump, what happens? The sodium influx is too much. The calcium is also there's also abnormal influx of calcium. Calcium accumulation also becomes too high because the metabolic function of the cell is lost, and water retention will also be seen, and K plus will be lost from the cell, efflux of K plus. So all this will lead to the swelling of the endoplasmic reticulum. Whole cell will be swelled. Microvilli is lost because there's blubbing. Blubbing is formation of as a result of cellular swelling, all the bubble-like formation of the cells ends are seen. Villi is gone, and the villi are they are formed into blebs. Then anaerobic glycolysis. As I told you, the glycogen will be decreased for the production of lactic acid. So when lactic acid is produced, pH is going to decrease. That will lead to clumping of nuclear chromatin. There's also detachment of ribosomes that will lead to protein synthesis. So this is what occurs all in all in ischemia. So that's all about ischemia. Now we are going to a next topic, that is free radicals. It's important. It's a bit long, but then we'll try to do it. Okay, so before we go into free radical, we have to understand what is ischemic reperfusion and free radical cell-mediated injury. You have to understand what it is. So we have already seen now, as of now what we have seen, there's cell injury, there's decreased, I'll tell you all in a summary, there's decreased cell injury, there's cell injury, so there is decreased oxygen supply. So when there's decreased oxygen supply, there is decrease in ATP. So when there's decrease in ATP, what happens? The overall metabolism of the cell is shattered. Everything is decreasing. The glycogens are being converted. So cell is in a injured state, right? So that is this ischemic condition that we are talking about. So ischemia can go in for three conditions: a reversible injury, a irreversible injury, and a reperfusion injury. Now, if ischemia occurs, and if ischemia is can be converted into a reversible cell injury. When it can be converted into reversible cell injury? Yes, when the stimulus is withdrawn, or when the stimulus that causes ischemia is very mild or transient. That is, when the oxygen supply is re-established, or when the blood supply is re-established, what happens? Ischemia can come back to normal because it will become reversible injury. Now, from ischemia to irreversible, that is, if the stimulus is not withdrawn, or if the factor keeps on continually injuring the cell, it reaches to such for a prolonged time, so such that it reaches to a state where you cannot withdraw the stimulus. Even if you withdraw, there's no use. Even if blood flow is established after a long time, there's no use because it has gone into a irreversible cell injury. Okay, and this irreversible cell injury, one thing you have to understand is that in irreversible injury, here, this case, there is no free radical production. But in some cases, what happens? There will be reperfusion injury. That is, well, you know what it is. Here also ischemia will be for a longer duration. So what happens? Ischemia means the cells are getting destroyed, right? So cells are getting injured. So these injured cells will try their best, like they are at the verge of death. Still they are injured and living. So they'll try their best to supply blood to the parts, all the parts. Though they are injured, they try to be viable as much as possible. Though they are injured, they'll try to do their work by continuing the perfusion. But they're injured. But what happens then? Along with that, there will be destruction of the injurious cells. The injurious cells will try their best to do the function of a normal cell. Then they get destroyed. So that small thing that it does, that is called reperfusion injury. So why this reperfusion injury occurs? It occurs due to three things. That is because of free radical production. For free radical production is the reason happens to be why the cell, though it is injured, it will try its best to do its work and then it dies. So ROS formation is one reason. Then there is increased calcium overload. Then there is inflammatory reaction that we'll be studying later. So first we'll go in for increased production of free radical generation or increased production of ROS, that is oxygen derived free radicals, which occurs due to oxidative stress. Oxidative stress means when there's a condition of hypoxia and oxygen is unavailable. Now the definition of ROS. What is free radicals? Free radicals, they are chemicals with single unpaired electron in the outermost orbit. Free radicals, they can exist freely and they have a single electron in their outermost orbit. They are very unstable, okay, and very reactive. Unstable in the sense they are highly reactive. So they react readily with the organic and inorganic substances of the cell, that is with the nucleic acids. It will try to react simply with the nucleic acids, proteins and lipids. So it is actually useful to a good extent because it will try to keep away the microbes that try to attack the cell, or it will try to keep a check on the signaling pathways of the cell. If it is too much also, it's bad, no? So it keeps an eye on the signaling pathways and it kills the microbes. But if ROS is not properly eliminated out of the cell, then it will go and interfere, cause destruction to our nucleic acids, to the proteins and to the lipids, causing destruction. So ROS, as we told, it is oxygen derived free radical which is formed in the cell due to normal redox reactions in inflammation. That is, as I told you, ROS main function is killing of microbes. ROS is that is a reactive oxygen species is so much increased during the following conditions like ischemia, when there's abnormal chemicals deposition, when there's radiation, when you do chemotherapy too much such that it even damages the normal cells. The cells can go, there will be ROS problems. Then when there's aging, okay, like that. So these are the conditions. Now ROS formation again can be physiological formation and pathological formation. Physiological formation, it occurs in all cells. You have to understand that it occurs almost in all cells as a normal thing. Like it has a few functions like killing of microbes that might enter, or controlling the signal pathways to a small extent. So as you can see here, oxygen is being converted inside the cell. Okay, it is being converted into superoxide. That's octooxidation which occurs here. The superoxide is being converted into H2O2 by superoxide dismutase, which you can see here. H2O2 is again converted into OH minus by the ion. You can see here Fe3 plus being Fe2 plus. So that is called Fenton reaction, or H2O2. In the presence of catalase H2O2 or glutathione peroxidase, that is this GSH. So in the presence of either of these enzymes, H2O2 can directly go in for formation of H2O, or the OH radical which is formed as a result of Fenton reaction after radiolysis, which you see here, it can go in for formation of water. So this is what it occurs usually. So I told you about Fenton reaction, right? H2O2 in the presence of iron, Fe3 plus is converted to 2 plus, so H2O2 converts to OH minus, so that is called Fenton reaction. This is physiological, normal thing. But pathological, it occurs when there is phagocytic Leukocytes, they are overphagocytic, so they'll initiate the formation of ROS, overreaction of ROS. In phagosomes and phagolysosomes, the ROS are formed by the process of oxidative or respiratory burst, which leads to formation of O2 minus and H2O2. Okay, that is what it is. This I told you already. In the cell, when there's cell deprivation, we already talked about phagosomes and phagolysosomes. They, in the absence of oxygen, they try to eat up the cell. They try to destroy the cell. So the first step to destruction of their cell is respiratory burst. When there's no oxygen, or no nutrition, when the cell is suffering from hypoxia, the first step that lysosome does is this oxidative or respiratory burst. So that leads to production. So there will be very little oxygen maybe. So that will be converted into the ROS, reactive oxygen species, like superoxide, this one, O2 star or O2 minus and H2O2. Then there is also conversion of free radicals. The other free radicals, sometimes they may be converted into HOCl by the mitochondrial peroxidase and also by the lysozymes. You can also see that NO, that is nitric oxide, is being formed here. That will lead to formation, and by the action of free radicals, that will be converted to, that like superoxide, it will be converted to this peroxynitrite, that is ONO. Then removal. So this is what usually occurs in normal cases. Removal of ROS, that should happen. So how that occurs? It is occurs as a result of spontaneous decay. Unstable spontaneous, usually it just comes off, it does all what it has to do, then it decays. Unstable spontaneous decay. Or sometimes the O2 minus, which might be left in the cell, the SOD will convert it into peroxide, hydrogen peroxide, and GSH, glutathione, will convert H2O2 to H2O and OH minus. Or sometimes the catalase can convert the, as you can see here, catalase can convert the peroxide to water. Or most commonly we have our antioxidants. That's where vitamins also come into role, like vitamin A, vitamin C, the beta carotene. So all these are the antioxidants which will actually block the formation of free radicals and destroy them. So they'll keep an eye on excess ROS. So as I already told you, normal function is killing of microbes and yes, signaling pathway. The cell injury occurs when formation exceeds the removal. So that's when cell injury occurs. It's not when ROS forms cell injury occurs. ROS formation is normal, but it has to be to a small extent. If formation of ROS is so much and degradation of ROS is less than usual, then it goes in for cell injury. That's what we have to understand. So that can lead to lipid peroxidation of membrane, protein degradation, DNA damage. So these are the consequences of excess ROS, that is reactive oxygen species. Excess interference can lead to lipid peroxidation of membrane, protein degradation, and DNA damage. It is clearly mentioned in this diagram. Okay, we'll go we'll see. See, oxygen enters the cell. So there's mitochondria. So there's incomplete reduction of the oxygen inside mitochondria. So it is converted into superoxide. Superoxide is converted into H2O2. You know how? It is by superoxide dismutase. And by femton reaction is converted to OH minus. Then you know that process, radiolysis, where it will be converted into water. So that's a very common process that occurs there. So, and their overproduction will be looked up by the antioxidants which will be in the cell, or the SOD. All those enzymes will keep an eye on the increase of ROS. But if there is an inflammation to that cell in the form of radiation or chemicals or reperfusion, injury, or if there's reperfusion, if any of those conditions happen, what happens? Okay, our cell mechanism will first try to remove the very common process that occurs there. So, and their overproduction will be looked up by the antioxidants which will be in the cell, or the SOD. All those enzymes will keep an eye on the increase of ROS. But if there is an inflammation to that cell in the form of radiation or chemicals or reperfusion, injury, or if there's reperfusion, if any of those conditions happen, what happens? Okay, our cell mechanism will first try to remove the free radicals, as I told you now. Antioxidant action will be there, or SOD action will be there, which will convert O2 minus to H2O2, and H2O2 will be converted to the OH minus in water. The GSH will convert the OH minus to H2O2. Catalase will try to convert H2O2 into H2 and O2. So all these free radicals will be converted into safer molecules, which is okay for the cell by antioxidants, SOD, GSH and catalase, which you can see here. But if that doesn't work, or if production is too much to be handled, then its destruction, it can lead to pathological effects. The ultimate result of this action of the reactive oxygen species is cell injury and cell death. If it is prolonged, it will go in for cell injury and cell death. So as we told, if it is too much, it will react with fatty acids, proteins and DNA. If it reacts with fatty acids, what happens? There will be increased oxidation. So that will lead to generation of lipid peroxidase. So what will, our plasma itself is made up of lipid membrane, bilayer lipid membrane. So if this ROS is going to disturb the fatty acids, and there will be production of lipid peroxidase, and hence there will be whole disruption of the lipid, which constitutes the cell membrane. So there will be whole disruption of the cell membrane. The cell membrane is getting destroyed along with the organelles which have lipid membrane. Then in the case of proteins, if it acts on proteins, again oxidation occurs. Increased oxidation will lead to loss of enzymatic activity. If that is so much continued, it can even mutate, or it can even cause abnormal folding of the cells, of the cell structures. This ROS can do it. Then DNA. Finally, when it acts on the DNA, which is inside the nucleus, DNA will undergo oxidation, and again, if the cell injury is prolonged, it can go in for mutation and breakdown, maybe sometimes even to apoptosis actually, because cell mutation injury is a very serious condition. So it has to be taken care of in the first attempt itself. It has to be understood in the first attempt. So that's all about ROS. So how ROS creates problems. ROS is needed, as I told you again. I'm telling it again. See, it is actually a normal thing for ROS formation. But if it is more, it becomes pathological. Next, we go in for calcium metabolism. That is, there's increased calcium in the cells. How this calcium increases in all these injured cells? We'll see. There's failure of ATP-dependent calcium pump, which leads to increased calcium in the cytoplasm. So when you have ATP decrease, what happens? We already talked that when there is decreased ATP, there will be dysfunctioning of the ATP-dependent sodium pump, as well as dysfunction of which one? Yes, ATP-dependent calcium pump also. When you have the sodium pump, which is not working and not allowing the sodium to get out, similarly, you have the calcium pump also, which is dysfunctioned. It is not allowing the calcium, excess calcium in the cell to get out. So what happens? There will be increased calcium inside the cell, cytoplasm of the cell. And along with that, so this will stimulate, unnecessarily this will stimulate the cell organelles like ER, that is endoplasmic reticulum, and or mitochondria also to secretes calcium. So overall, huge amount of calcium, intracellular calcium is seen. So what will what will calcium do? Calcium will this abnormal amount of calcium will start stimulating various enzymes, like these three enzymes which are mentioned here. That is phospholipase, protease and ATPase. These three enzymes are highly stimulated. So phospholipase, they are going to destroy, they are going to digest the phospholipids that will lead to membrane damage. And proteases will lead to membrane and proteases means they are going to destruct all the protein components, the enzymes, enzymes are proteins. So all the cell enzymes, everything is going to be destroyed. So that will again damage the membrane and cytoskeleton of the cell. Then ATPase is finally going to increase the breakdown of ATP. So finally the cell is in a complete breakdown in all terms. Its membrane is breaking down, all the cell organelles are breaking down, ATP is breaking down, cell itself is completely prone into cell injury. So this is a small pictorial representation of that. See, you can see here that the calcium, that is Ca2 plus extracellular calcium, There is actually a pump here. It is not mentioned in the diagram. It is actually ATP dependent calcium pump here, which will get inside the cell and do its functions. But if there's an injurious agent, what happens? The ATP dependent calcium pump will dysfunction. It won't work properly. So what happens? Calcium can get in the cell, but it can't get out. So calcium is increased in the cell. So along with that, this will stimulate the mitochondria as well as the endoplasmic reticulum to secrete calcium. So there is so much of increased cytoplasmic calcium that will lead to ATPase secretion, phospholipase secretion, protease secretion, endonuclease secretion. So all these will lead to their own damages. Like nuclease, they'll damage the nuclear chromatin. Protease, we have already talked, proteins. Phospholipase, obviously the lipids are damaged. ATPase, the ATP is damaged. So the whole cell membrane damage begins. Now, etiology of cell membrane damage. How it occurs, the cause. It can be ischemia or any microbial toxins like, any virus or bacteria affecting the cell and producing toxins can also lead to cell membrane damage. Or any lytic agents. Actually, all those are dealing, these lytic agents and microbial toxins are dealing with entry of microbes. They'll try to divide, and as a result, the host cell is destroyed. So that is what is another cause. Then any other physiological or chemical agents which the cell faces. Then pathogenesis of cell membrane damage. How this pathology is caused in cell membrane damage? We have already talked this. I'll just go through first. That is, there's increased phospholipid breakdown. We know phospholipase is so much stimulated by calcium. So there's increased phospholipid breakdown. Along with that, ROS is also so much increased. Protein synthesis is decreased. Protein degradation is increased. Cellular ATP is decreased. So because all those ASE, all those enzymes which will destroy all these things will be activated by your calcium. That's what happens. Then lipid breakdown happens. So lipid breakdown products are, you can see here, unesterified free fatty acids, lysophospholipid, and acyl carnitine. So this will get accumulated. These breakdown products will start accumulating in the cell. So that can lead to cell damage. There's also leakage of cellular and organelle contents outside this. Because the cell membrane is destroyed, the cell gets openly injured. So all the organelles leak out. Everything, cytoplasm, protoplasm, everything leaks out of the cell. Now, plasma membrane, there is loss of osmotic balance in the plasma membrane. The cellular contents, they leak out. Mitochondria, there is increased ROS production and decreased ATP production. Lysosomal membrane, they'll initiate, what they'll do. They are suicide bags of the cell, right? So they'll try to destroy the cell as such by stimulating degradation proteins like protein enzymes like proteases. Then ER, in the endoplasmic reticulum, there will be decreased protein synthesis. Then there's severe DNA damage that will certainly lead into cell death or apoptosis. Actually, DNA damage is actually dealing, if it is not at all taken into consideration, if it is not at all reversed at the particular time, it can go in for apoptosis. But if the DNA damage is mild, as you know, if a stimulus is withdrawn, it can come back to normal, or else can even cause, either it can cause mutation or cancer or apoptosis. Protein damage and misfolding is also an important reason for cell death. Now, when does reversible injury become irreversible? It occurs when there is cessation of ATP. There is no ATP production. First, we told ATP production will be decreasing, and because ATP is being simply broken down by ATPase. But if this keeps on continuing and if there is no production, if breakdown exceeds production, then also reversible injury becomes irreversible. Then if there is lysis of the cell membrane, when there is absence of vital proteins, when there is failure of vital metabolic function, so all these can lead to irreversible cell injury from a reversible form. Now, ischemic hypoxic cell injury, we've already talked of this, we'll just revise it. Ischemia means, it is increased blood supply and increased oxygen and nutrition, and hypoxia means decreased oxygen. So initially, the cell first, the beginning, when there will be hypoxia, that stimuli will start. So that is initial hypoxia. So at that time, there will be decreased ATP. Decreased ATP, you can connect and see. ATP decreased means ATP dependent sodium pump will not work. And the ATP dependent calcium pump also will not work. So sodium and calcium is increased in the cell. The glycogen of the cell is decreased because there's no oxygen. So anaerobic glycolysis is required. So this glycogen will be used up. There will be decreased protein synthesis, which will lead to cell swelling and fatty change. Now, if the hypoxia is very persistent, again calcium is too much of influx of calcium will occur. It will lead to the activation of all those the lytic enzymes. Then there will be increased ROS. Then cell membrane damage ultimately, because everything is being digested, everything is being broken down due to hypoxia. If it is persistent, only this occurs. This leads to further prolonged means it will lead to cell death or necrosis. Then reperfusion itself R for ROS. So there mainly ROS are being released. So much of ROS are being released. And the injured cells, they'll try their best to increase the oxygen supply. That is what is meant here. Increased oxygen supply right from injured cells. They'll try their best to increase oxygen supply. Then there is increased ROS. There is increase in inflammation, blood stasis, and there's more ROS formed. If there's so much ROS increase, that will lead to necrosis. And finally, a weak reperfusion, cell death, if this condition is not withdrawn. So finally, we come into the last topic, chemical injury. We've already seen, as the name itself suggests, chemical injury is an injury that is caused by chemical agents. These chemical agents, they'll either directly combine with some component of the cell, any component of the cell, or maybe directly to a cell organ. Chemical injury can occur in two ways. Okay, there will be directly acting chemical agents and indirectly acting chemical agents. Two types. So directly acting chemical agents means these agents will cause maximum damage to the cell organelles as soon as the cell organelles act on them, or as soon as the cells use them for metabolysis. For unfortunately, they may not be knowing it is toxic or poisonous, those agents. So they'll directly act on those toxin agents, and that will directly go in for on their metabolizing property will lead to cell injury, chemical injury. So the example is mercuric oxide poisoning, mercuric chloride poisoning, cyanide poisoning, and anti-neoplastic chemotherapeutic agents. All those radiations, if they are too much. So they are also kind of chemicals which are directly can act and destroy the cell. Now there are some agents which are indirectly acting. That is, when they are inside the cell, they got into our body, they reach the cell. They are inactive. But the cells, what they'll do? They'll act on these poisonous substances, or they'll act on these chemical substances which are inactive, convert them into active metabolites, and then try to excrete them. So what happens? There will be injury and damage to those cells which try to convert those toxic chemical agents to their active form. So that is indirectly acting. So example is CCl4 poisoning, where it is converted to CCl3 in the liver. So we'll see the pathogenesis. That's the last thing. So this chemical injury occurs by two mechanisms, that is ATP inhibition and cell membrane damage. So these are the two mechanisms, ATP inhibition and cell membrane damage. So as you can see here, CCl4 in the presence of smooth endoplasmic reticulum, CCl4 is actually a component in the smooth endoplasmic reticulum, in the sense when we take some organic compound by chance, or somehow CCl4 compound is formed in the SCR, smooth endoplasmic reticulum of the liver, it will be immediately converted to CCl3, which is an active metabolite. CCl4 is inactive, CCl3 is active. CCl3 in the presence of microsomal polyenoic fatty acids. Liver will have some kind of fatty acids in them. So in the presence of that, it will convert those small fatty acids associated with liver into lipid radicals. And lipid radicals means free radicals, they'll try to go and communicate, or they'll try to go and bring about more free radicals. So in the presence of this O2 plus or superoxide, it will lead to lipid peroxidation, that is autocatalytic spread along microsomal membrane of the liver, of all the liver cells. So lipid peroxidation can lead to two things. Okay, that is release of products of lipid peroxidation. There will be many products released as a result of, because lipids are being destroyed. Lipid peroxidation means the lipids are being oxidized abnormally. So that can lead to degradation products of lipids. Here you can see here, this is it. And the membrane damage to RER. Now, membrane damage to RER, RER means rough endoplasmic reticulum, can lead to polysome detachment. That is, RER means rough endoplasmic reticulum, where you have ribosomes attached to the ER. So these ribosomes will detach from those endoplasmic reticulum. So there is decreased apoprotein synthesis. Everything is decreased, so that can lead to a fatty liver. That's one scenario. Another one is there's release of products of lipid peroxidation. The lipid peroxidation products are released. So that can lead to the damage of plasma membrane. Because plasma membrane is made up of lipid. So that is going to get damaged on the increased action of our lipid peroxidase. So when it is damaged, it becomes permeable, it becomes opened out. So there's permeability of Na plus, Ca2 plus, H2O. So all these things will start accumulating. You already know the pumps are all regular. When the cell is at the verge of cell injury, all the ATP pumps, calcium dependent, sodium dependent, all these are not working properly. So the water, calcium, sodium all simply try to get into the cell, and the cell will swell. That is called cell swelling. Simple thing. That is along with that, there will be a massive Ca2 plus influx, which will lead to inactivation of mitochondria, cell enzymes, and there will be complete protein degradation. So this cell swelling and fatty liver are the consequences of a reversible cell injury. If it is not converted back to its normal form soon, it will go for irreversible. So I know it was a long topic, but I hope you all understood about this. We had a quick we'll just have a quick review. Okay, we talked about, I'm not going to tell anything once again. We just we studied about cell adaptations, what they are: atrophy, hyperplasia, hypertrophy, metaplasia. We studied about that, what it is. Then we went into cell injury, what is cell injury, all those stuff, when it occurs, ischemia, hypoxic states, or the ROS factors that lead to hypoxia, all those things, and cell injury. So next will be classification of cell injury, which will be dealt in cell injury part 2 on 27th. So hope you all understood. Thank you.